Right. Now the first question is, nalorphine is used as an antidote for all the following except morphine, pethidine, pentazocine and heroin. Now all of you know that the opioid receptors are of four types: mu, kappa, gamma, delta and sigma. Right? Mu, kappa, delta and sigma. Now the mu receptors are again divided into two types, that is mu1 and mu2. Now the mu receptors, they basically mediate supraspinal analgesia, respiratory depression, and physical dependence, and muscle rigidity, So these are basically mediated by the mu receptors, that is supraspinal analgesia, respiratory depression, physical dependence and muscle rigidity. Now agonists to mu receptors are morphine and fentanyl. So these are the agonists to the mu receptors. Now on the other hand, the second receptors are the kappa receptors, and the kappa receptors, they basically mediate sedation and spinal analgesia. Right? Agonists include again drugs like morphine, nalbuphine. Agonists are drugs like morphine, nalbuphine. So these are the agonists for the kappa receptors. Then another are the delta receptors. Now delta receptors basically mediate analgesia and they are epileptogenic and behavioral. Right? So they provide analgesia, epileptogenic and behavior. And then the last is the sigma receptors. The sigma receptors, they basically mediate dysphoria, hallucinations, and respiratory stimulation. Examples include pentazocine and nalorphine. Examples are pentazocine and nalorphine. So these are the agonists at the sigma receptors, both pentazocine and nalorphine. So nalorphine is used as an antidote for all the following except morphine is a mu agonist, pure mu agonist, pethidine again is a pure mu agonist, and heroin is a derivative of morphine. So the answer to question number 1 will be pentazocine, because pentazocine is agonist at the sigma receptors, but it is antagonist at mu receptors. It is antagonist at the mu receptors. Right? So answer to question number 1 is pethidine. Now question number 2. Methglobinaemia is caused by. So what is the cause of methglobinaemia? Now, methglobinaemia is caused by certain local anesthetics, and the most commonly it is caused by prilocaine. Most commonly it is caused by prilocaine. Now, prilocaine is metabolized to O-toluidine. It is metabolized to O-toluidine. So all of you know again that the local anesthetics are divided into two groups, amides and esters, and prilocaine is a amide local anesthetic. It is a aminoamide. It is a amide local anesthetic. Now the other agent which also causes methglobinaemia is benzocaine. It is used as a 20% spray, used for some endoscopies and bronchoscopies, and it very commonly causes methglobinaemia. Now, treatment of methglobinaemia is intravenous methylene blue. This is the treatment for methglobinaemia. So what about the other drugs? For example, procaine. It is local anesthetic of choice in patients with history of malignant hyperthermia. It is a local anesthetic of choice in patients with history of malignant hyperthermia. Bupivacaine. It is a long-acting local anesthetic. Bupivacaine is long-acting local anesthetic. Concentrations used are 0.5% heavy for spinal anesthesia and 0.125% for painless labor. 0.125% for painless labor. Now, the maximum safe dose of bupivacaine is 3 mg per kg body weight with or without adrenaline. Maximum safe dose is 3 mg per kg body weight with or without adrenaline. Now, then the bupivacaine should never be given as intravenous injection. It should never be used as an intravenous injection. It is contraindicated for intravenous regional anesthesia. It is contraindicated for intravenous regional anesthesia. Now, as far as lignocaine is concerned, lignocaine is intermediate acting local anesthetic. It is intermediate acting local anesthetic. Again, it is amide. Now, concentrations of lignocaine used are 5% heavy for spinal anesthesia, 5% heavy for spinal anesthesia, 4% topical anesthesia, 1% nerve blocks, and 0.5% for intravenous regional anesthesia. 0.5% for intravenous regional anesthesia. 2% jelly is used for urethral procedures. 2% jelly is used for urethral. For example, you have to put a Foley's catheter or do a cystoscopy, then you apply 2% jelly. Again, what is the maximum safe dose of lignocaine? Maximum safe dose of lignocaine is 3 mg per kg body weight without adrenaline and 7 mg per kg body weight with adrenaline. Maximum dose is 3 mg per kg body weight without adrenaline and 7 mg with adrenaline. So, answer to question number 2 is prilocaine. The other agent which can cause is benzocaine. Now, question number 3. The following are used for treatment of post-operative nausea and vomiting following squint surgery in children except ketamine, ondansetron, propofol, dexamethasone. Now, all of you know that squint surgery is associated with a high incidence of nausea and vomiting. Now, ondansetron is an antiemetic. It is an antiemetic drug. Propofol has got antiemetic effect. Propofol is antiemetic, antipruritic, anticonvulsant, and antioxidant. So these are the antis which are associated with propofol. Dexamethasone is a steroid, and steroids have it is associated with decreased incidence of nausea and vomiting, especially when you give it with chemotherapy, right? It is basically used in chemotherapy, but refractory type of nausea and vomiting can respond to dexamethasone. Now, ketamine is one drug which is not associated with nausea and vomiting, right? It does not have any antiemetic effect. It is not does not have any antiemetic effect. No antiemetic effect. Ketamine, right? Also remember, ketamine increases the intraocular pressure and therefore should be avoided in eye surgeries. It increases intraocular pressure, therefore avoided in eye surgeries. So what are the other effects of ketamine which you should know? Now, ketamine causes increase in blood pressure and heart rate. Causes increase in blood pressure and heart rate, and therefore it is drug of choice for acute hypovolemic shock patients. It is drug of choice for acute hypovolemic shock patients, right? If the shock patient is coming and for example a stab injury, a gunshot, and patient has got a acute blood loss and it needs to be operated, then ketamine will be the drug of choice for acute hypovolemic shock patients. Now, also ketamine is contraindicated in hypertensive patients, ischemic heart disease patients, and aneurysm patients. Ketamine is contraindicated in hypertensive patients, ischemic heart disease patients, and aneurysm patients. Now, ketamine is a potent bronchodilator and drug of choice for asthmatic patients. It is drug of choice for asthmatic patients. It is a potent bronchodilator. Now, ketamine causes minimal respiratory depression. It causes minimal respiratory depression. Now, ketamine increases the ICP. It increases ICP, and therefore it is contraindicated in space occupying lesions of the brain. It is contraindicated in space occupying lesions of the brain, any tumor, cyst, hematoma, anything which occupies space in the brain. For epilepsy patients, so it is a contraindication, and for head injury patients, right? So answer to question number 3 is A. Ketamine should not be used for squint surgery. It does not provide any antiemetic effect. Now, Question number 4. Which of the following is a contraindication for using a laryngeal mask airway? When inhalational anesthesia is required, large obstructive lesion in the oropharynx, maintaining airway during difficult intubation, emergency management of airway in failed intubation. Now, a laryngeal mask airway is a supraglottic device. It is a supraglottic device, that is, it remains above the level of the glottic opening. Now, it is not a definitive airway. Not a definitive airway. Now, definitive airway is a airway which forms seal inside the trachea. Since LMAs do not form seal inside trachea, therefore it is not a definitive airway. Now, so what are the indications of LMAs? LMAs are used for short surgical procedures, for difficult airways, for CPR, right? So they are used for short surgical procedures, for difficult airways, for CPR. Contraindications to LMA are full stomach patients. For example, a patient who have a recent meal, he will full stomach, and therefore is a contraindication for LMA. Similarly, pregnancy, hiatus hernia, right? Morbidly obese patients, all these considered to be full stomach. Full stomach means any patient who has got a higher gastric residual volume, that is full stomach. Now, what are the other contraindications? Inadequate mouth opening, patients with low pulmonary compliance, for example, morbidly obese. Patients with low pulmonary compliance, for example, morbidly obese, and patients with oral pathologies. So, for example, patient has a tumor in the oral cavity, right? Carcinoma base of tongue. All these will be a contraindication for LMA. Now, the size of the LMA depends upon the weight of the patient. The size of the LMA depends upon the weight of the patient. So, according to the weight, the LMA is inserted, right? And always you will prefer for a higher size, right? You will prefer for a higher size of LMA because that forms a better seal. So, what is a contraindication out of these? When inhalation anesthesia is required, this is not a contraindication. LMAs are used along with inhalation anesthesia. Large obstructive lesion in the oropharynx, again, large obstructive lesion in the oropharynx is a contraindication to LMA, right? Any oral pathology will be a contraindication for LMA. Maintaining airway during difficult intubation, again it is used for difficult intubation algorithm, it is used. And emergency management of airway in failed intubation, it is again a device which is used in difficult airway or in failed intubation. So, the answer to question number 4 is B, large obstructive lesion in oropharynx. Now, question number 5. The anesthetic agent can be used during labor for intrauterine fetal manipulations as it causes profound uterine relaxation. Now, all inhalational anesthetic agents, they cause profound relaxation of the uterus. Halothane causes maximum, and therefore halothane is also the agent of choice for manual removal of placenta. It is also the choice for manual removal of placenta. Other inhalation agents, they also cause uterine relaxation. Not that much as caused by halothane, but a significant degree of uterine relaxation is caused by other inhalation agents, including dasflurane, isoflurane, enflurane, and sevoflurane. Now, if you give inhalation anesthetics at the time of the caesarean section, that can lead to postpartum hemorrhage. Right? Use of inhalation anesthetic at the time of caesarean section under general anesthesia can lead to postpartum hemorrhage. So, what about the few points regarding desflurane? Now, desflurane has lowest blood gas coefficient among the inhalation anesthetics, and therefore it has got faster induction and recovery. Fast induction plus recovery. Also, it is most pungent smelling. Desflurane is heated to a temperature of 39 degrees centigrade. Desflurane is heated to a temperature of 39 degree centigrade. So, if you want to give desflurane, you will have to switch on the vaporizer, which will heat it to a temperature of 39 degrees centigrade. Why? Because desflurane has got a very high vapor pressure. And delivery of the agent depends upon the vapor pressure. Also, desflurane has lowest boiling point, 23 degrees centigrade. Now, desflurane is minimally metabolized in the body. It is minimally metabolized in the body less than 0.1%. Now, sudden increase in desflurane concentration can cause hypertension and tachycardia. Sudden increase in desflurane concentration causes hypertension and tachycardia. Now, desflurane, it reacts with dry soda lime to produce carbon monoxide. It reacts with dry soda lime to produce carbon monoxide. So, answer to question number 5 is B, desflurane. Now, question number 6. Post-dural puncture headache results from leakage of CSF into subdural space, increased hydrostatic pressure in subarachnoid space, relieved in upright posture. Triptans might be needed for treatment. Now, as far as post-dural puncture headache is concerned, it occurs due to leakage of CSF from dural puncture site. Right? Now, so whenever you give spinal anesthesia and the spinal needle will come out, it will leave a small hole, and through that hole there will be leakage of CSF. Now, it occurs usually 24 to 48 hours after spinal anesthesia and can last up to 7 days Usually by the 7th day it is relieved. Now, it is a low pressure headache. So unlike meningitis, which is a high pressure headache, it is a low pressure headache. Now, the headache is increased in sitting and standing position and decreased in lying down position. This is very pathognomic of this headache. If the patient is complaining of a continuous headache which is not having any positional uh, correlation, then you cannot label it as a post-dural puncture headache. Then it could be meningitis also. But in post-dural puncture headache, when the patient will lie down, the patient will say, okay, my headache is now less, it is relieved. But in sitting and standing position, the headache increases. Now, the headache can be prevented by using pencil tip needles. Headache can be prevented by using pencil tip needles, by using higher gauge needles, by using higher gauge needles, by giving adequate hydration, right? Now, the headache can be these are the prevention, can be treated by analgesics, bed rest, analgesics by sodium coffee benzoate, triptans. These are used basically for migraine kind of headaches, but they can be used for post-dural puncture headache, right? Can be used for post-dural puncture headache. Most definitive treatment of post-dural puncture headache is epidural blood patch. This is the treatment of choice. So what you do is you take 15 ml of blood from the antecubital fossa and inject it into the epidural space. And once it is injected into the epidural space, what will happen? It will form a clot and it will seal the dural puncture site. So that is the most definitive treatment, that is epidural blood patch. So answer to question number 6 is D. Triptans may be needed for the treatment. Conditions are drugs which cause a rise in CBP include all except, this is not IPPY, it is IPPV, intermittent positive pressure ventilation, IPPV. Heart failure, nitroprusside and Valsalva Minova. So what are the conditions which cause a rise in central venous pressure? Now, the conditions which increase CVP are hypervolemia, congestive cardiac failure, cardiac tamponade, coughing or straining, for example Valsalva Minova, coughing or straining, then positive pressure ventilation, IPPV, and pleural effusion and hemothorax. On the other hand, the CVP is decreased in hypovolemia or shock. It is decreased in hypovolemia or shock, and it is decreased by vasodilatation. The vasodilatation will cause a relative hypovolemia. For example, drugs like nitroprusside, nitroglycerin, they cause vasodilatation and they will decrease the CVP. Now, as far as the sites for CVP are concerned, most commonly used is the right jugular approach. Right jugular approach, that is the most common site which is used. Other sites include subclavian vein and femoral vein. Subclavian vein and femoral vein. Now the main drawback while using subclavian vein, main complication which can occur is there could be pneumothorax. Although the main most common complication is subclavian artery puncture. Main complication is pneumothorax. Most common complication is subclavian artery puncture. That is the most common complication. So answer to question number 7 is C. Nitroprusside does not cause an increase in CVP, it causes a decrease in CVP because it is a vasodilator. Now, which of the following is not a coaxial circuit? Now, coaxial circuit is a circuit which contains a tube inside a tube, like this. It contains a tube, there is an outer tubing and there is an inner tubing. Now, so what are the coaxial circuits? Coaxial circuits include LACs, which is a modification of Mapelson A, or McGill circuit, Baines, which is Mapelson D, Penlon is a modification of Baines, modification of Baines, then Mira F, which is again just like Baines, and Humphrey ADE system, which is a combination of Mapelson A, D and E. So all these are coaxial circuits. Now, as far as the circuits are concerned, Mapelson A is also known as McGill circuit. This circuit is best for spontaneous ventilation. When the patient is breathing on its own, this circuit should be used. So this is best for spontaneous ventilation. The fresh gas flow is equal to the minute volume of the patient. Fresh gas flow is equal to the minute volume of the patient. Then comes Mapelson B, it is obsolete. Then comes Mapelson C. Mapelson C is also known as Waters to and fro circuit. This is used for transportation of the patient. C circuit, transportation of the patient. Then comes Mapelson D. Mapelson D is also known as Baines circuit. This circuit is best for controlled ventilation. The fresh gas flow is 1.6 times the minute volume of the patient. 1.6 times the minute volume of the patient. Then comes Mapelson E. Now, Mapelson E is also known as Ayer's TPs. Mapelson E. Now, modification of Mapelson E is known as Mapelson F, which is Jackson-Rees modification. Right? So, Mapelson F is used in children less than 6 years or less than 20 kg. It is used in children less than 6 years or less than 20 kg. So answer to question number 8 is D. Jackson Rees is not a coaxial circuit. Now, question number 9. Which of the following agent is long duration ester for local anesthetic agents? Now, you can divide the local anesthetics into two groups, that is amino ester and aminoamide. Now, amino esters, you can see they contain only one I, while aminoamides they contain two I's. Now, amino esters are metabolized by plasma pseudocholinesterase except cocaine, which is metabolized in the liver. They are unstable compounds and they are metabolized to para-aminobenzoic acid. They are metabolized to para-aminobenzoic acid, which is responsible for high incidence of allergic reactions. On the other hand, aminoamides are metabolized in the liver. They are stable solutions and they have less incidence of allergic reactions. Now, so as I told you, bupivacaine contains two I's, so it is an amide. Cocaine is a ester, but it is intermediate acting. We are looking for a long duration. Lignocaine is a amide. Tetracaine is a ester, which is of long duration. It is a ester which is of long duration and is and it is used for spinal anesthesia. Tetracaine, it is used for spinal anesthesia. So answer to question number 9 is D. Answer to question number 9 is D. Now, question number 10. The volatility of an anesthetic agent is directly proportional to lowering of the flow in portal vein. Portal flow is maximally reduced by. Now, portal flow is maximally reduced by halothane. Halothane causes maximum reduction in portal flow. Isoflurane maintains the portal flow. Isoflurane maintains the portal flow, while halothane causes maximum reduction in the portal flow. So, what are the other points which you should know about halothane? It is a sweet smelling. Thiamol is added for stability. Now, halothane causes hepatitis. It causes hepatitis. Pathology is centrilobular necrosis. Pathology is centrilobular necrosis. Most common cause of halothane hepatitis is multiple exposures at short interval of time. Multiple exposures at short interval of time. Mortality is 30 to 50%. Mortality is 30 to 50%. Now, what are the other points about halothane? Halothane is a potent bronchodilator, and again drug of choice for asthmatic patients. It is drug of choice for asthmatic patients. It is a potent bronchodilator. It causes severe depression of hypoxic ventilatory drive. Severe depression of hypoxic ventilatory drive. Right? Now, in the CNS, it causes an increase in ICP. Whenever you give halothane, there is a cerebral vasodilatation and there is an increase in ICP. Prior hyperventilation is required to prevent rise in ICP. Prior hyperventilation is required to prevent rise in ICP. It does not provide any analgesia. I have already told you it is a potent uterine relaxant and therefore used for manual removal of placenta. So, answer to question number 10 is halothane, right? That causes maximum lowering. On the other hand, isoflurane maintains, and fluorine also lowers it, but not to the extent halothane. So, answer is halothane. Thank you.